Welcome to AETCM EM Rapid 2023. Today we'll be discussing about acute exacerbation of COPD. So COPD, as we know, it is a chronic obstructive pulmonary disease which is characterized by persistent respiratory symptoms and airflow limitation. It is due to secondary to airway or alveolar abnormalities. And it is caused by significant exposure to noxious substances or gases. So a COPD patient often presents with complaints of persistent symptoms of dyspnea, chronic cough or sputum production, and also give a history of exposure to these non-risk factors like cigarette smoke. So as defined by Global Initiative for COPD, there is GOLD by WHO. COPD is defined as a heterogeneous lung condition characterized by chronic respiratory symptoms like dyspnea, cough, sputum production, and recurrent exacerbations, and it is due to abnormalities of the airways resulting in bronchitis and bronchiolitis, and also alveoli resulting in emphysema. And it causes persistent and often progressive airflow limitation. Even though we say the most important risk factor for COPD is cigarette smoking, only 15% of smokers will develop the actual disease. The other risk factors are occupational dust, like in coal mining, and also chemical exposure and recurrent lung infections, especially viral infections like adenovirus, and also air pollution. And also, less than 1% is contributed by alpha 1 antitrypsin deficiency in certain patients. So, pathophysiology basically, COPD is an inflammatory response to the lungs by various noxious substances, and it results in airway obstruction resulting from a combination of airway secretions, mucosal edema, bronchospasm, and bronchoconstriction. So, the central element of the chronic lower airway obstruction is mainly due to impedance to the expiratory airflow, and it is due to increased resistance by decreased caliber of the small bronchi and bronchioles. So there is actually a increase in the resistance of airway due to acute bronchoconstriction to the small vessels like small bronchi and bronchioles. And this exaggerated airway resistance can reduce the total ventilation of the patient and also can cause increases the respiratory work. So, acute exacerbation is when a patient comes to the ED or to the hospital with complaints of an acute event which has happened within a period of less than 14 days with persistent dyspnea, cough, and sputum production. And exacerbations are often associated with local and systemic inflammation caused by airway infection, pollution, or any recent insult to lungs. So, as symptoms are not specific, particularly only to COPD, we have to think about other differences also when we are getting this kind of a patient. So, we have to think about relevant differentials like pneumonia, congestive heart failure, and pulmonary embolism. So, when a patient is coming with complaints or symptoms of COPD exacerbation, we have to think about other differentials. The common ones are, as we discussed, pneumonia, pulmonary embolism, or heart failure, and less common ones are like pleural effusion, pneumothorax, and even acute MI. So, we have to do relevant investigations like getting a chest X-ray, get an ECG, echocardiogram, or even do a probe in to rule out heart failure, or maybe we can send for lab reports like cardiac enzymes and also D-dimer, and even do a CTPA to rule out pulmonary embolism. So these are all the differences which we have to think about when we are getting a patient with a probable exacerbation of acute COPD. So the assessment will be like initially we take a thorough clinical assessment, and after that we look for symptoms, severity of dyspnea, and also clinical signs like tachycardia, tachypnea, and also we ask history about the sputum volume, sputum color, and also we observe the patient for use of accessory muscles as a sign of respiratory distress. Also, we have to evaluate the severity by using appropriate additional investigations like pulse oximetry, laboratory measures like CRP, Procal, and other investigations, and also arterial blood gas, which is very important in COPD patients. And while at that, we had also had to think about the actual cause of this acute exacerbation. It could be a viral or bacterial infection, or maybe some environmental factors like an exposure to significant cold or dust, smoke, like that. So that will be our approach to a person who is presenting with acute COPD. So next we have MMRC dyspnea scale, which is a modified MMRC scale dyspnea scale, which we can use as a clinical tool to grade the patient in accordance with the severity of dyspnea. So grade 0 will be the person, it's a regular person, like he gets breathless when he's doing strenuous exercise. Grade 1 will be he's feeling breathless when he's hurrying up his level ground or walking uphill. Grade 2 will be he's walking slower than counterparts or like people of similar age group because of breathing difficulty. And grade 3 will be he's not able to complete even 100 meters without stopping to take breath. And grade 4 will be he's too breathless even to leave house or even to dress himself. So when a patient is coming with complaints of acute exacerbation, when should he get admitted? The first and most important is severe symptoms like sudden worsening of resting dyspnea, high respiratory rate, decreased oxygen saturation, or any acute altered symptom like confusion or drowsiness, and any signs of acute respiratory failure like an increased PCO2, a low pH, etc. in the ABG, and also any onset of new clinical physical signs like any new cyanosis or peripheral edema noted, and also failure to respond to initial medical management. Then any presence of serious comorbidities like any already pre-existing heart failure and also any newly occurring arrhythmias, etc. And lastly, any insufficient home support. If the patient is not able to be taken care of at home, better to get admitted. Then let's think about conditions which warrant say ICU admission. The first one is severe dyspnea that is responding inadequately to emergency therapy. Second will be acute change in mental status after coming to ER or even on the way. So it will be like confusion, lethargy, or even comatose. So third will be persistent or worsening hypoxemia with a POA2 for 40 of less, and then severe or worsening respiratory acidosis with increasing PCO2 and also lowering of pH less than 7.25, despite giving supplemental oxygen and ventilatory support by NIV and other supportive measures. Next is need for invasive mechanical ventilation. These patients needless anyway have to get admitted in ICU, and also any patient requiring hemodynamic support like vasopressors in case of hemodynamic instability. All these conditions warrants a patient to get admitted in critical care unit. So we're getting a patient with probable signs of an acute exacerbation of COPD. We have to think about first thing to confirm the diagnosis or to rule out differentials. Differentials which we have already discussed before. Once we are diagnosing that, we have to treat them accordingly. So now we are coming to an acute exacerbation of COPD. We have to classify them as mild, moderate, and severe. So mild will be a dyspnea scale less than 5 with a respiratory rate less than 24, heart rate less than 95 beats per minute, and a resting SaO2 more than 92% in room air with no other supplementation. And also, if you're sending a lab, you will be getting a usually inflammatory markers less like CRP less than 10 milligram per liter. And moderate will be dyspnea scale more than 5 with increased respiratory rate more than 24 beats per minute, heart rate more than 95 beats per minute, and an SaO2 less than 92% in room air, in which case the patient might need supplementary oxygen. And also, CRP will be more. In case of severe COPD exacerbation, the parameters will be almost be similar to the moderate, except along with that, the patient might show an acute or a new onset or a worsening hypercapnia with acidosis or worsening respiratory acidosis going into impending respiratory failure. So, while we are assessing the patient for this kind of grading and all that, we have also have to think about the etiology of the acute exacerbation. So, for that, we have to send the patient's blood samples for viral testing, sputum culture, etc. In our current clinical scenario, even COVID-19 is also a very important cause factor for acute exacerbation. So treatment goals, our priority is to like correct the tissue oxygenation, alleviate reversible bronchospasm, and treat the underlying cause. So whenever a patient is coming with COPD exacerbation, our primary aim is to like limit or minimize the negative impact of the current exacerbation and also to prevent recurrence. So in a mild case, we can be treated with short-acting bronchodilators. Moderate, we can treat with short-acting bronchodilators along with an oral corticosteroids or even antibiotics as required. And also severe exacerbations might require ICU admission and also more advanced care. So the key component of the first priority is to provide adequate oxygenation. Even though a COPD patient, we have to limit the amount of oxygen we are giving to the patients. Oxygen is the key component of the first thing we have to manage in a COPD patient. So our target will be to maintain a SpO2 level of 88 to 92% with supplementation. Supplementation devices which we can use depending on the requirement, like nasal prongs, oxygen mask, or even HFNC can be used in certain conditions. So once the oxygen is started, we have to frequently monitor the patient for any worsening of respiratory acidosis and also any improvement in the oxygenation levels. So we have to do recurrent blood gases to follow up that, because sometimes pulse oximetry may not be an adequate or an optimum choice for some certain patients, especially in Individuals with darker skin, it can give wrong readings. So, especially in COPD patients, arterial blood gas is a better choice, or even VBG can be used in certain conditions. So, it is a better choice than pulse oximetry in following the patients. So, once oxygen is started, we have to continuously monitor the patient for improvement in oxygenation and also to look out for any worsening of CO2 retention and worsening respiratory acidosis. So once oxygen is taken care of, the second part is bronchodilation. So the initial management is by short-acting bronchodilators, and once the patient clinically improves, we switch over to the long-acting bronchodilators. So the drug of choice with the commonly used ones will be salbutamol or estalin, which we we get as respules, which we can give at 2.5 milligram will be available at 2.5 ml respule, which we can put in the nebulizer and give. And similarly, we also have like combinations like levosalbutamol with ipratropium bromide. Ipratropium is again an anticholinergic, which can again relieve the bronchospasm. In certain conditions, we might also have to give inhaled broncho like steroids. So inhaled short-acting steroids can also be given, like budesonide can be given along with the other medicines to relieve the bronchospasm. So coming to steroids, steroids are not always indicated in COPD patients, but in certain conditions it can actually improve the lung function, oxygenation, and also shorten the recovery time. So especially in cases where we have like severe exacerbations and patients we are having increased eosinophil level in their blood, steroids have been proven to be much useful. So we recommend a dose of about 40 to 60 milligram per prednisolone or equivalent dose of other steroids can be given per day, and oral is also preferable in the patients who can take orally. And usually the duration of therapy will be normally for not more than 5 days. There are multiple studies actually that have been conducted to assess the pros and cons of steroid therapy in this kind of patients, and some of them have actually shown to be like negatively affecting certain patients. Like one observational study actually suggested that longer courses of oral steroids can actually cause or predispose the patient to pneumonia or even increase the mortality. So whenever we are using, preferably give for a duration less than 1 week. So next is antibiotics. Again, antibiotics, just like steroids, we can give in certain patients which can improve the recovery time and also reduce the risk of early relapse, treatment failure, and also reduce the number of days in hospital. So initially, we can give an empirical treatment with aminopenicillin with clavulanic acid, like augmentin can be given, and macrolides can be given, tetracycline can be given, and certain patients we can even opt for quinolones. Especially in India, quinolones are a reserved drug because it is used as a second line drug in tuberculosis. So it is better to start with a drug like aminopenicillin with clavulanic acid as an initial choice of drug. But in certain conditions like any severe airway obstruction, significant like exacerbation or even sick patients, we have to send cultures from sputum and other materials from lung, like bile culture and everything should be sent to find the exact causative organism, because sometimes other organisms like gram-negative bacteria like Pseudomonas species etc. can be, or even resistant pathogens can be the causative organism for the acute exacerbation. And in these conditions, this antibiotic may not be adequate. So whenever getting a sick patient, better to go for send the cultures the initial space itself, and depending on the grown bacterium, we can change the antibiotic. So next is non-invasive ventilation. In a acute COPD exacerbation patient, this is one of the best and the life-saving devices which we can use in an ER. So it should be used the first mode of ventilation used in COPD patients with acute exacerbation and impending respiratory failure, because it can improve the gas exchange, reduce the work of breathing, and even can avoid the need for intubation. And over time, it can reduce the duration of hospital stay and also improve survival. So in all these aspects and with no absolute contraindication, NIV can be used in almost all patients. A very few contraindications are like low sensorium, significant hemodynamic instability, etc. And so, considering that all patients receiving NIV should be put on continuous hemodynamic monitoring, because it can actually adversely affect the hemodynamics like blood pressure and all that. So we have to put them on continuous hemodynamic monitoring. But apart from that, it is one of the best options we can give for a COPD patient with acute exacerbation. So indications, the most important thing is respiratory acidosis and impending respiratory failure. So a patient who is having a PaCO2 of more than 45 milligram per mercury and a arterial pH less than 7.35 is a good candidate for NIV. And second will be severe dyspnea with clinical signs sensitive of respiratory muscle fatigue, increased work of breathing, and even obvious use of accessory muscles. And all these conditions we can use NIV. And third will be persistent hypoxemia despite supplementary oxygen therapy. This patient, the hypoxia may improve only with some additional PEEP, which the NIV can provide, and so we can give NIV for this kind of patients also. Even after all this, even after starting NIV, some patients may not improve. Those patients might require or have to go for invasive mechanical ventilation. So the first thing will be the persons who are unable to tolerate NIV or going into NIV failure. Second will be post cardiac arrest or post respiratory arrest. Then third will be worsening or diminished consciousness, psychomotor agitation, which is inadequately controlled by sedation. Then massive aspiration, which can again get worsened by using NIV, or persistent vomiting. Especially to protect the air, we go for invasive ventilation. Then persistent inability to remove respiratory secretions by the patient himself, and severe hemodynamic instability with not much response to vasopressors or fluids. Then severe ventricular supraventricular arrhythmias. So basically, an unstable patient, we have to opt for invasive ventilation. And by last, life-threatening hypoxemia in patients who are unable to tolerate NIV. Either we are using a NIV or a invasive ventilation. One of the utility is to provide some additional PEEP which can actually improve this hypoxemia. So a patient is in life-threatening hypoxemia state who is not able to tolerate NIV. The best option is to go for early intubation. So if you're putting a patient on a ventilator, this can be used as a reference guide for initial ventilator settings. The first thing will be we set the FiO2 to target an SpO2 of 88 to 92%. Then we use mode assist control ventilation or even SIMV can be used. And then a tidal volume, our early target will be around 6 to 8 ml per kg. And respiratory rate will be set low as 12 to 14. And also ISO ratio will be increased to 1:3 or even more depending on the record expected time constant. And flow rate we can start with 80 to 100 liters per minute. And also peak inspirator pressure we have to maintain between less than 40 to 45. And also peak plateau we have to maintain less than 30 centimeters of water. And also the triggers need to be adjusted between -1 to 2 centimeters of water. So the basic idea is if the trigger is too sensitive, the patient can even go into respiratory alkalosis because of hyperventilation. And if the trigger is too high, then you can increase the work of breathing and again can actually cause difficulty for the patient. So this will be like a sweet spot -1 to 2, not -1 to 2, 1 to 2. So next is PEEP setting. We can always start with the basic PEEP setting of 5 centimeters and see how the patient responds. If the patient is having persistent hypoxemia, we can actually think about increasing the PEEP. The issue is once the PEEP is increased, the patient can have like start fighting with the ventilator. So PEEP need to be like frequently monitored, and also increasing PEEP can cause worsening of hemodynamics. So we have to keep a watch on the peak plateau and hemodynamics, and also peak inspiratory pressure when we are adjusting the PEEP. And also, especially in COPD patients, there are also it's a high chance of auto PEEP developing over a period of time, which we also have to monitor. So once the patient improves and we are discharging the patient, we have to definitely start them on a long-acting. We have to start them on a long-acting beta-2 agonist, which will like prevent further exacerbations in the future. So we can start with a long-acting beta-2 agonist. Along with we can start low dose inhaled corticosteroids as a double combination, and also we can even add a third drug, which is an anticholinergic, which can again improve the long term condition of the patient. So we start with a long acting bronchodilator along with a low dose inhaled corticosteroid along with an anticholinergic. This will be the drugs which will be given for discharge. And depending on the patient status and the patient's tolerance, we can suggest them to use a dry powder inhaler or even a metered dose inhaler. And we can also teach them to use spacer and all depending on the patient. And also we can advise them to take a low carbohydrate, high protein diet. This is highly beneficial for COPD patients. And patients who are requiring continuous oxygen even after recovery, we might have to send them home with supplementary oxygen to be used at home, which we can advise to start with a rate of 2 to 4 liters per minute continuously for at least 16 hours per day. Giving continuous supplementation of oxygen can actually improve the status of the lungs over time. So these are the basic idea of discharging a patient post recovery in a COPD exacerbation. So to sum up, so we have a patient with acute exacerbation of COPD. The first one will be we assess the severity of symptoms. We classify according to the dyspnea this thing category classification. Then we do basic blood investigations, blood gases, and also chest radiograph. We first thing is oxygenation. We provide adequate supplemental oxygen therapy, and then we monitor the patient with serial arterial blood gas, and also or even venous blood gas can also be used, and also put them on continuous pulse oximetry. And third will be bronchodilation to relieve bronchospasm, which initially we start with short-acting bronchodilators and then we switch over to long-acting once the patient improves. And also we combine along with anticholinergics and also low-dose steroids. So short-acting, long-acting, low-dose steroids and anticholinergics are the nebulizations which we use for improve the patient. And then in case of significant bronchospasm and other conditions, we can think about starting them on oral corticosteroids like prednisolone can be started, or even methylprednisolone can be started. And then consider antibiotics, especially if oral if tolerable, tolerating patients in case of signs of bacterial infection. So the most common, like from clinically, we can assume bacterial infection in a patient who is having a new onset of purulent pus, because purulent sputum when he's spitting it out. The color, the definition of that color will give us a clue that the patient may be having a bacterial infection. And consider NIV in any patient who is significantly breathless, showing any signs of respiratory, impending respiratory failure, even this thing, respiratory acidosis. So all these patients need to be continuously monitored for their fluid balance in the ICU. We have to think about giving or even consider giving a subcutaneous heparin or low molecular weight heparin to prevent thromboembolism. And also we have to identify and treat the associated conditions like any concomitant heart failure, arrhythmias, pulmonary embolism, or anything that may present along with this acute exacerbation. So that is in short acute exacerbation of COPD. Thank you.